Hello, I'm Suzan Song, Director of the Division of Child, Adolescent and Family Psychiatry at George Washington University, and a Humanitarian Protection Advisor for survivors of forced displacement globally and domestically. There has been an unprecedented surge in the number of displaced people worldwide, including refugees, asylum seekers, undocumented immigrants, and unaccompanied minors. Around the world, more than 65 million people are currently displaced by war, armed conflict, or persecution. As of early 2018, almost 31 million children worldwide were displaced by violence and conflict. If these current trends continue, 1 in 100 people will be a refugee in the near future. Unfortunately, most refugees and survivors of forced displacement will not receive needed mental health care due to scarcity of services, lack of access to qualified care, and stigma against mental disorders. Refugees are those who have fled their country of origin due to well-founded fears of persecution based on race, religion, nationality, political opinion, or membership in a particular social group. Whereas refugees request protection while overseas and are given permission to enter the U.S., people seeking asylum also have a well-founded fear of persecution, but they seek protection while inside the U.S. Refugees and other conflict-affected persons are reported to have a 15 to 30% prevalence of PTSD and depression, compared to the 3.5% prevalence of PTSD among non-refugee populations. The strongest predictors of poor mental health are exposure to torture and the cumulative number of traumatic events, but torture, separation from family, stressful asylum processes, isolation, and disadvantage in the host country all worsen mental health. The post-migration environment, mainly prolonged detention, insecure immigration status, poor access to services, and limitations on work and education can worsen mental health. These do not provide the full scope of emotional issues that many conflict-affected persons face, including complicated grief, complex trauma, despair, isolation, anger, and lack of trust. Many people are experiencing normal responses to very abnormal experiences. Over time, most refugees show low or no symptoms, a small number show a pattern of gradual recovery, and a small minority remain chronic. So we need to evaluate the distinction between situational forms of distress and a clear mental disorder for refugees. We do this by focusing on a dynamic interplay of exposure to past traumatic experiences, ongoing daily stressors, and the core psychosocial systems that one is embedded in. Psychiatrists can help these populations with culturally competent clinical work with refugees and asylum seekers, at a policy level by conducting asylum evaluations, and at the advocacy level by promoting equity of access, sustainability of services for refugees and forcibly displaced people, and by partnering with interdisciplinary community members such as lawyers, educators, and policymakers to provide a safe system for which refugees and survivors of forced displacement can rely on.